That's actually our first criteria when we're doing a diagnosis.
If you were sitting with me,
yes, there has to be some kind of negative impact in your life from this. So that could be getting arrested for a DUI or losing relationships because I'm not paying attention to them, or I'm acting impulsively or doing things I wouldn't normally do in a state of intoxication. It has to be affecting your life negatively in some way. And then we have a list of 11 different symptoms, and you actually only have to have 2 of those to qualify for an alcohol use disorder.
Okay.
So I think that threshold is actually lower than what people would expect, but it's also not this black and white thing of I'm either an alcoholic or there's no problem at all.
Well, hey, everybody, this is Jesse Karajat, host of the Live Deep podcast and founder of Altum Fitness. I am here with Kori Turner. Kori, how are you?
Great. How are you?
I'm doing good. Thanks for being here. As you can tell, it's different for us this episode. Normally, virtual, remote. Kori happens to be in Northern Colorado. She is a licensed professional counselor and licensed addiction counselor. We're going to get into what that is and the different ways that folks who are needing help or treatment can get that help with folks such as Kori. Kori, I want to start by saying this. We're going to dive deep on a couple different topics, mainly addiction, trends in addiction, what's happening in our culture, society, and then we're going to dive a little bit deeper on alcohol abuse, getting to know you offline a little bit. You know that I have a personal story with that, and I think it's relevant. I think a lot of people are struggling with it. Before I do, I think it's important for people to know and understand when I say licensed professional counselor and licensed addictions counselor. I don't think that everybody knows, what types of different professionals, passion professionals are out there to help folks that are struggling with that. So can you just give an overview of yourself, your background, your credentials, and then kind of walk us through and teach us about that?
Absolutely. So a licensed professional counselor just means that I have training and education in counseling. So I'm bound to certain ethical guidelines, legal guidelines, things like that. That just means that I have that professional training. And I have, I'm obligated to uphold certain standards in the care that I provide. You can have lots of different kinds of credentials to provide counseling. So you might be a social worker or a psychologist, but it's a little bit different than maybe a coach who might have some training, but is just providing a little bit of a different service. And then licensed addiction counselor means that I've done some additional training specifically in addictions to be able to provide that kind of specialty service.
Okay, so if someone wants to be a counselor, they first become an LPC.
Most people who become a counselor will become like a LPC, LCSW, things like that.
Okay.
Certain states have addiction-specific credentials, and so an LAC is Colorado's highest addiction credential.
And why did you personally go down that path and dedicate your career towards the specificity of an addictions counselor?
Well, I think I came into the field to start just because I wanted to do meaningful work and help people. I have personal experience with mental health and substance use. I have people close to me that experience that. There's no way to avoid substance use when you're helping people. And so I wanted to be prepared and knowledgeable to do that in the best way that I could.
Let's stay there for a second. So there's no way to avoid, if you're going to be a counselor, no way to avoid running into, my words, addiction or substance abuse. So there's a strong correlation between mental health, emotional fitness, and...
Absolutely.
Yeah. Why do we think that is?
Absolutely. Well, first, you may not even run into it in terms of every person that you're going to see has a substance use problem, but chances are they have somebody close to them that does, and they may be affected in some way. So it's unavoidable. There's the correlation between like mental health and substance use is really strong. I think there's like a 50% or higher correlation. So we know that trauma, for example, can put somebody at an increased risk for developing substance use, alcohol problems. There's certain mental health diagnoses specifically that have a higher correlation. You may just have a genetic predisposition to be more at risk for developing an addiction. So if you were just born with less dopamine or serotonin in your brain, you might be more apt to seek things that give you that dopamine or serotonin release. And drugs and alcohol are really reliable at doing that. So
you said 50%?
That's probably a conservative
Wow.
number.
So the fact that you can be born with a genetic predisposition to develop a substance abuse later in life, that's today's science. That's what is out there.
And I'll say these things are really complicated, so I am oversimplifying them.
Thank you for that.
And I'm aware of that. But it's not necessarily that you are born more likely to become addicted. You may just have certain predispositions that would put you more at risk of that. That's to say, all addictions start with that initial use of a substance. So you can have a mental health issue and never use substances. But
yeah. And on that note, is that because the other big elephant in the room, the other factor is where you're raised, who you're raised around, exposure to those substances?
Yeah, so even outside of a genetic predisposition, exposure to family substance use or just having family mental health stressors definitely can put you more at risk for just starting use early yourself, but also just seeing that as a way to manage emotions and relationships and problems, just seeing that kind of coping pattern being modeled. We tend to learn how to manage our emotions by seeing what the people around us do.
I want to repeat that for myself. Seeing coping patterns being modeled, that's huge. Anecdotally for myself, and we're getting to know each other, but I was raised in a house, separated house, so divorced parents, and on both sides you had substance use, and it was at the time social mostly that I saw, but then at other times it felt like it was more of like a coping thing. So when I think about myself and my history of alcohol abuse, started around 14. Lots of trouble, lots of run-ins with the law, and so we've covered it on this show. But when I hear you talk, and I think about like a genetic predisposition, and then I think about environment, I can start to give myself some kind of grace because I felt like I was stepping into this world with both. And then you layer on top of that where I was raised and athletics and the Jersey Shore and just the kind of like party hard type environment. I don't think I had a chance.
Yeah. And, alcohol specifically is so normalized in our society as like just a thing that you do. Not only do we see those patterns just culturally, but yeah, seeing that in your family, it's just like, oh, this is a normal thing to do.
Yeah. Yeah. We're diving right into it. So let's just keep going. So we started talking about addiction a little bit. What I wanted to do and hope to do, and we'll go down rabbit holes, but is talk about, I want to hear your answer to a question because I don't want to assume that everyone knows what addiction is. But we'll start with like, what is addiction? Talk a little bit about what's happening in the brain. You already mentioned some key things that I think the general public are starting to zero in on, like dopamine. My hunch is serotonin isn't talked about quite as much or understood as much. And those have an inverse relationship, yeah? Those two? No?
I think it can be a little complicated, but
okay,
yeah.
We'll go there. We'll go there. But the brain science of addiction, and then we'll kind of spend the rest of the time specifically on alcohol, and then even more specifically, alcohol use disorder, and maybe some other frameworks, paradigms that are more known to the public, like Alcoholics Anonymous, stuff like that. But starting with addiction, if you had to try, to just kind of define what it is and then move towards like what's happening. Let's talk about it. So what is addiction in a medical way or maybe even a conversational way?
Yeah, clinically, when I use the word addiction, what I'm referring to is a chronic brain disease in which the reward pathway in our brain gets hijacked from the consistent use of drugs and alcohol. So I am referring more to that medical model of our understanding of addiction. I know socially and culturally, the word addiction gets thrown out a lot, maybe in ways that aren't appropriate or accurate. So saying that I have like a Starbucks addiction, I think it can be thrown out and sometimes muddy the waters in terms of what that means and maybe what we associate with that. Yeah. So I'm using it in a clinical sense that we understand it as kind of a disease in that disease model of what's happening in the brain and how that affects our emotions, our behaviors, our relationships.
Yeah, and you used the word chronic. Say more about that.
Yeah, we see that once a dependence develops on a substance for some of the chemicals that we need in our brain, without treatment or without some effort to address it, becomes a chronic pattern.
Chronic means just continuous, but not necessarily forever? Or is it?
It can be reversed
Yeah.
and addressed, and without any effort to do so, I would expect it to continue.
A little bit of curveball here. Digital. I'm going to go down the digital addiction route. But when you use the word substance connected to addiction, I understand that you're not simplifying it so that only addictions are substance, things you ingest at least orally or into your body or into your other ways. But how would you talk about digital addictions? Whether it's and like. I'll give you a little diatribe, but like I developed an addiction where if I'm talking to someone and someone brings up a topic and I need to know, like if it's like trivia, like I can't just move on. I have to go like Google it to find out. I feel like I've developed a habit, which could be an addiction, to like impulsively knowing things. And then there's more insidious known things like social media. But would you classify digital addiction as like a major problem today, up there with substances, or are they kind of separate in the way that you talk about them clinically?
Well, we do have a kind of separate set of addictions called process addictions, which are more behaviorally related. So this would include things like disordered eating, sex addiction, things like that. So these are other behaviors that interact with our reward pathway. And we know that a lot of our technology is designed to kind of hijack that same system. So I would say it's certainly part of our behavioral addictions. I'm not necessarily a specialist in behavioral addictions, but process addictions, but I think that's an undeniable concern.
Yeah, so we have process addictions, substance abuse addictions. I'm sure maybe there's some other types or not, but
those are the ones that we have diagnoses for.
Okay. And talking about the brain, are similar mechanisms at work? Are similar things happening on both sides of those?
Yes.
Yeah? Can you talk a little bit about what's happening in the brain?
So what happens is, let me start by saying that dopamine is probably the single most important neurotransmitter involved. Again, it's much more complicated than this, but I'm going to simplify it for the purposes of the conversation. So dopamine is the chemical in our brain that gives us a sense of pleasure. It's what motivates us to do things. So what happens in the brain is there's certain behaviors, in this case also substances, alcohol, that interact with our reward pathway. So the reward pathway is what releases dopamine into our system. We get dopamine in other places too, but that's the primary way that we get dopamine released. So that part of our brain exists to cause us to repeat behaviors that we need to keep surviving. So I need to keep eating. I need to keep procreating.
Surviving. Okay.
So this is tapping into a pretty primal part of our brain. Just so happens that substances cause our brain to release lots of dopamine. And what happens is we initially get an exponentially larger release of dopamine in our brain than what we would normally have. And so that's what feels really good initially. But then what happens is that causes us to be in a dopamine deficient state. So we get a really big dopamine release, but then over time, that release is smaller and smaller and smaller until it's actually a fraction of what we would normally have without substance use. So how that affects our behaviors is without enough dopamine, we can't get out of bed. We can't do those things that are really important to us. So that's why we see with people who have a long-term substance use disorder or addiction is that it's hard for them to even function. And it's because they're in this chronic dopamine deficient state.
Now, is that because the normal way, quote unquote normal, but the everyday way, absent from substances or was it called control addictions? I'm sorry, was that the other type? Process, thank you. Is that because the dopamine release is so much lower, smaller, whatever you would say, that when you introduce this foreign substance that just spikes it up, your body is responding less and less to those natural dopamine releases and it becomes reliant on the more intense ones?
That's right. So then we don't get enough pleasure and reward from the things that are essential to our survival, which is why we see folks kind of disengaging from relationships, not taking care of themselves. It's not necessarily a conscious choice that they're making. It's just that they're not getting the dopamine that they need from those experiences to continue repeating those patterns.
Wow. Well, and so essentially your life revolves around that substance, because that's especially if survival is underneath, that's a powerful motivator.
Yeah. So what happens is we start with that initial intoxication that can become a pattern. And then what happens is when you stop using, you're in a withdrawal state that can affect your emotions and behaviors really negatively. And that increases cravings. And so then you enter into this anticipation and preoccupation with substances. So you're in this pattern of intoxication, withdrawal, and then preoccupation.
This is so silly, but I'm trying to understand, and this is how I do it. And I'm a visual person, so I'm picturing a hot water heater, right? And it's filled up with dopamine that has been released from whatever substance that you've kind of fallen into that trap. To ask this question, I'm kind of using this visual, but when that water heater runs out, and presumably in your brain, the dopamine runs out, and you find yourself in this state where it's not there, does it not refill right away? And that's what withdrawal is?
Yes.
Okay. So then how does someone get out of that situation? What does it feel like? And I don't know, I'm not saying that you have this personal experience, but like, how long can that last? I'm assuming it's substance, contingent on whatever the substance is, but I can see how it'd be so difficult to kind of move on and to start slowly filling that tank back up, because the easy, quote unquote, short-term solution is probably just to go back to what filled it up in the first place. Yeah.
That's going to be the most reliable way to do that. And that's why we see people get stuck in that pattern. But that doesn't mean that somebody's going to stay stuck forever. It does mean that it's going to be really difficult to start to heal the brain. So there's going to be a lot of really difficult decisions to make. That's why we see that folks tend to need a lot of support in that process. Maybe they need medical treatment or medications initially to kind of stabilize some of those things.
Honic Set Point. I know enough about it to say it and loosely understand it. But what I experienced in my own personal journey at times, because there were multiple times in my life when alcohol had a very strong hold on me. And talking about it through this lens, I can totally relate that it was probably the only place that I was finding dopamine. And one of the things I noticed, even in that state, was I wasn't enjoying or noticing simple things that used to give me these very small bouts of pleasure. For example, where we're sitting here in northern Colorado, for folks that obviously haven't seen where I live, I'm directly across from a park. There's beautiful views of the sky, sunlight coming in. A lot of times, especially in the summer, kids laughing. There's a pool up the street, the sound of the pool. I can remember moving here and getting joy. And it wasn't intense, long-lasting joy, but I'd walk outside, I'd smell the air, I'd hear sounds, actually notice, and I would just get filled with this comfort and this peace. Juxtapose that with not long after I moved to Colorado, when I was burning out from work and managing life, having more kids, things like that. I stopped noticing those things, and I noticed that I stopped noticing those things. I stopped going for walks around the lake, and I kind of just, I don't know how to describe it, but went inward and just kind of put my head down. And the only time that I would feel myself finding those bouts of joy was when I was releasing from stress. But point is, big long diatribe, but I noticed that I wasn't getting those small little bouts of joy, and I started turning I'm pointing to water, but to alcohol. So the hedonic set point, if you could talk about it a little bit, but my understanding is that's your response to dopamine moves to a point where, unless it's intense, unless it's matching what the substance was or whatever your addiction was, you don't feel dopamine. Is that a loose kind of description of it?
It is. And I want to clarify that when we talk about the differences of dopamine, it's exponential. So we're intended to maybe be in this range, operate within this range of a dopamine, best day, worst day. And what happens with drugs and alcohol is it's way up here, but then it tanks to way down here. And so this might be a little bit different than a hedonic set point, which would be a smaller variance than what I would expect in clinical addiction or clinical substance use disorder. But you touched on something that's really important, just coming back to maybe even a genetic predisposition, is that there is a different part of the brain that they've seen in some research that tends to be more overactive in folks who have an addiction. And so that part of the brain is responsible for thinking about ourselves. And so for folks who have an addiction, they might be more likely to think about themselves. And we're not referring to things like selfishness and stuff like that here. It's just a part of the brain that's more active than maybe somebody else. Those things that you mentioned that you start to lose sight of are actually the things that can help us to offset that. So intentionally finding ways to look outside of ourselves, intentionally finding ways to use mindfulness. So there's lots of practices like that can help with all different parts of the brain and start to work towards stabilizing some of that chemistry. And
intentional takes effort.
Mm-hmm.
A lot
Absolutely.
of effort. You have to have motivation to apply effort. Yeah.
Undoubtedly. And I know it's hard to ask of somebody. I work with clinical addiction, so I tend to I see the range, but I do work with a lot of severe addictions. And it's hard to ask somebody in that severe dopamine state to have the motivation to go take a walk.
Yeah. But so in your experience then, if you're sitting across from someone, assuming it's not court mandated, I don't even know if that would be a thing in your world, but they have to have a clue or a motivation initially or a spark to know that they have an issue to be sitting across from you.
That's right. Yeah.
Yeah.
I would say everybody that I'm working with has come to me because they know that there's something that they need to change.
Yeah. I'm going to go back real quick to something you said, because I'm just curious about it, frankly. But you mentioned, and you went like this, you said, we're I don't know if you said this, but I'm going to say we're built to kind of handle this much dopamine.
Right.
But when we're flooding our systems with all of these external compounds and things, it's more like this. So you're saying that our minds, our bodies, we are literally not built. We don't have the capacity to handle that dopamine surge in our brain, is what you're saying? And we can't adjust. So our mind or our brain doesn't adjust to be able to accommodate that. And is that why we get into that situation where it's either that tank is full or depleted?
Well, I would say that at the far end of the spectrums, that's where we see those really significant effects on our moods and our behaviors. So it's not that we can't. It's just that we're not going to be very functional. We're not going to be able to do the things that are important to us because we are not going to have the attention and just not going to have the emotional and cognitive capacity to manage our lives the way that we would within that range that we're designed to operate within. So
it's debilitating in a sense.
Absolutely.
Yeah. Relating to addiction, and I'm just curious, in your clinical practice, and how long have you been in LA?
I've worked in behavioral health for 10 years.
For 10 years, okay. So in that 10-year span, perfect. When you think about addictions, what has changed? Has anything changed? Are you seeing more or less prominence of certain types of addictions? And just kind of culturally, as a society, what have you seen, and even where do you see us heading?
Yeah, that's a great question. Unfortunately, the rates of addiction are increasing fairly significantly. These are complex issues. I'm sure there's lots of socio-political, biopsychosocial factors that impact all of these things. I think we've all gone through some shared experiences that can be traumatic for people, so that might increase some of the rates. There's been changes in substances themselves that have made a more recent impact. So in the opiate crisis that we're in, just with there's these synthetic analogs. That's what fentanyl is, and we've heard fentanyl a lot.
Yeah. Analog?
It's a synthetic analog, so the chemical structure is just a little bit different. An analog is just one kind of change in the chemical structure, but that change affects the body in really unpredictable ways. And so with these synthetic drugs, it's just not as predictable. So some of our treatments aren't as effective. So that's certainly something that's changed specific to opiates. But in a larger sense, there's just been an increase in things like loneliness, depression, and anxiety. People tend to go to drugs and alcohol to cope with difficult or intolerable emotions. And
Yeah. Something, just to respond to that, something I find to be confusing and paradoxical is you mentioned loneliness, isolation, stress, anxiety. I'll try to keep this short, but what seems to be very confusing, and I can't wrap my head around this, but you have all of this technological innovation, better medicines, better connectivity, supposedly, social media, the intent is to connect, yet you have more isolation, more loneliness, more distance. And you're saying is absolutely driving addiction, which is you're coping with those feelings. Not necessarily a question in there, but I'm assuming that as you sit across from your patients, your clients, I'm assuming that they're sharing some of those feelings about being isolated and lonely.
Undoubtedly.
And we are supposed to, as a society, be inventing things that make life better. Yet anything I'm exposed to, anything I read when I talk to people like you, it feels as though we're heading in the wrong direction, not the right direction. And that's sad to me. And I don't understand that,
yeah,
frankly.
I think it's disappointing that maybe things are being designed in a way to take advantage of our attention and the way that our brain works. And the other side of it is there's some pretty unbelievable tools that we have access to now that certainly change the landscape for the better. But I think we can be really intentional about how we use the tools that are available to us. And they are kind of designed to take advantage of some of our vulnerabilities.
Yeah. Specific. How about alcohol? In the 10 years that you've been, working in this field, I've heard COVID was a major factor, and a lot of people talk about isolation, things like that. I know drinking trends, whatever. But alcohol in particular, would you say that is an increasing trend, decreasing? What's your gut or your actual experience
Well,
there?
I think the research shows that has increased over time as well, as you mentioned, since COVID, increased rates of opiate and alcohol use. Alcohol itself maybe hasn't changed in such drastic ways as compared to opiates. So in that way, at least we know what we're working with. We've got some tools that tend to be pretty reliable. So I feel like we might be better equipped to address alcohol use disorder. And it feels like we're doing a lot of catching up with some of the other things.
Yeah, although I'll say I noticed beers are getting stronger and
That's
stronger.
true, especially here,
In Fort Collins.
the craft beer.
Yeah, in Northern Colorado, yeah. So I think those are getting more popular. But we'll turn the corner. We'll start talking about alcohol. You mentioned alcohol use disorder, and I want to start and say that I want to be sensitive to the different views around alcohol abuse. I'll use that term, the different ways we speak about it. You mentioned alcohol use disorder. There's other ways to talk about this issue, and there's other organizations loosely organized and tightly organized, things like Alcoholics Anonymous. So with respect to Alcoholics Anonymous particularly, they've obviously have impacted millions of people. There's some great things that kind of like social peer setting has done wonderful things. So to start off, I'll say that we'll respect any organization that's trying to help this thing.
Absolutely.
But I do want to go into where you focus and your, I wouldn't say beliefs, but the science behind like alcohol use disorder. And also, for the benefit of listeners, compare and contrast the differences between AUD, and that is the acronym, correct? People say AUD, so I will say that, AUD, and say a framework of AA and anything else that's out there. So I think it's good to just start with, what is alcohol use disorder?
So alcohol use disorder is a clinical diagnostic term that we use to diagnose and treat alcohol addiction.
Okay.
So it's clinical language, and we're referring to a specific set of symptoms that may indicate to us that somebody has developed an emotional or a physical dependence on alcohol. We tend to use alcohol use disorder and alcohol addiction kind of interchangeably. And previously, some of the diagnostic terms included things like alcohol abuse. And you'll even notice some of our big government projects still have words like alcoholic in them. However, that word specifically is more related to some of the history with Alcoholics Anonymous, and I'll kind of talk about that. So when we're looking at the differences between like a clinical approach to treatment and more of a social peer approach, One thing is that clinically, we're using that medical disease model to understand addiction and to help inform some of our treatment recommendations. So we understand, we use the understanding that we have now about the brain to help us maybe recommend certain treatments. So we're using a medical model, we're using person-first language, so we intentionally avoid using a term such as alcoholic, and we may say somebody with an alcohol use disorder or somebody with alcohol addiction. The history of alcohol treatment actually started with AA. So previously, the model that was kind of embraced by everybody to understand addiction was a moral model. So we perceived addiction as like a moral failing. It was a character flaw, something kind of wrong with that person. And we've evolved our understanding over time. And because that's where we started, people had a hard time getting the help that they needed from professionals. There was a lot of shame that came from that, and so not a lot of professional treatment was available, if any, in the beginning. And that's actually how AA developed, was a group of people who wanted to help each other because they weren't getting professional help, and they developed a program to support each other in recovering. So the roots of both are in that moral model. And I will say that the medical disease model is being embraced clinically right now. There is a lot to be said for the social support that you get in a mutual aid support group like AA or other groups. And I'll say that you can get support professionally too. Those boundaries are just going to look different, and people may have a preference for one or the other.
A couple things. There's a lot there. So I'll start with one. So the label. You said term, I'll say label, maybe it's the same thing. The label of alcoholic, would you say that if used correctly, it's only kind of being used within that AA framework?
I would say that I choose not to use identity first language in my work with clients. The person sitting across from me is more than their alcohol use disorder, and I think that using a label can be reductionistic in terms of only seeing that part of them. I also have heard from people that it can become important to them to identify as that, to have that as part of their identity. So when we look at some of the recovery research, not everybody who resolves a drug or alcohol problem identifies as like being in recovery. It's just not part of their identity. But we do tend to see that with like the more severe an addiction that somebody has, the more likely they are to kind of integrate that into part of their identity. So for some people, that is important to them.
Okay. And we chatted offline, and I'm getting to know you, and I know you're very sensitive, and I would say empathetic to in general. That only to say, I'll say anecdotally about the term alcoholic. One of the things that prohibited me from getting help earlier in my journey, because I knew alcohol had a grip on me, was my loose understanding of the permanence of the label. I don't know if I didn't want to, I refused to, but something about that didn't stick. Because I like to think, and life has shown me that if I apply myself hard, if I work hard, I have agency in my life, I can control outcomes in my life. It takes effort, discipline, hard work, those things. And I didn't like this notion that for me to get out of where I was, there was no getting out, no matter what I did. And so that, all of that to say, I can see if anyone has ever been turned off by that one notion of AA, I can relate with that. And a question that I would have is, when we think about alcohol use disorder, and I heard you say one other thing, alcohol abuse, and I'm still a little confused, is how we talk about someone. So if I'm listening, if I'm sitting here, should I be asking myself, is it the same question or are they different questions? Do I have alcohol use disorder, or am I an alcohol abuser, or is that like the same thing?
Yeah, great question. Yeah, previously we did differentiate between alcohol abuse and alcohol dependence. And as our understanding of addiction has evolved, we now perceive things as like you can be diagnosed with alcohol intoxication, but we would probably only do that if that was part of the reason, like the state of your intoxication is why I'm engaging with you. Now we just have alcohol use disorder, and there's a range of severity. So we have mild, moderate, and severe.
There it is. Okay. All right. So back to permanence of AA, quote unquote, versus the AUD model. And then now you just clarified it used to be alcohol abuse or alcohol dependence. And I'm assuming that's almost like alcohol abuse is on one side of the spectrum and dependence is the more severe. So now we've moved towards a mild, moderate, severe. So the question I should be asking myself, I guess, then is, am I on that spectrum?
Mm-hmm.
And if so, where?
Mm-hmm.
Yeah. Okay. Tracking. And then the question is versus the permanence model of AA. Can I move on the spectrum and potentially not be on the spectrum? Or is that too black and white to think about it?
I think that actually is the gray area. The black and white would be, I either have this or I don't, and I'm either going to get better or I'm not. The truth is in the middle. So we can see human behavior right on a spectrum. And when we're asking ourselves, is this a problem for me? Well, I think that would be the first question. Is this a problem for me?
Yeah.
Like, is this causing some kind of negative impact in some area of my life? That's actually our first criteria when we're doing a diagnosis.
If you were sitting with me, that's
yes, there has to be some kind of negative impact in your life from this. So that could be getting arrested for a DUI, or it could be I, am losing relationships because I'm not paying attention to them, or I'm acting impulsively or doing things I wouldn't normally do in a state of intoxication. So it has to be affecting your life negatively in some way. And then we have a list of 11 different symptoms, and you actually only have to have 2 of those to qualify for an alcohol use disorder.
Okay.
So I think that threshold is actually lower than what people would expect, but it's also not this black and white thing of I'm either an alcoholic or there's no problem at all. I think there's also something to be said for understanding, we call it the risky levels of use. So even if we take a diagnosis off the table, because some people have really strong negative feelings about that, they feel like a diagnosis is a label too. Even if we just look at risky drinking, for women, that's 4 or more drinks in one setting, or more than 7 or 8 in a week. I think that's probably a lot lower than what people would assume, or maybe that's just, maybe it was less than what I thought it would be.
8 in a week as a red flag is concerned, that would be less
for
than
women.
I would assume. Yeah.
So even if we just look at, are there risks with my use? Even if I don't feel like there's some huge negative impact in my life, is there risk with my current level of use? And the data would show, if you fall in that range, that yes, there's at least going to be some kind of risk to your health.
What would be maybe a second question or a third question? Like if you were, I'm not going to make you diagnose me, quote unquote, but if you were to sit here with me, the first one, let's assess the risk, my words here, but damage in your life, relationally, maybe professionally, whatnot, health-wise. What would be like a second or maybe even a third question that you would ask?
I would probably ask what you want to be different about that. I think that's the benefit of kind of working with a professional, is that they're trained to kind of guide you and following your own goals and values to make a change plan, because you're more likely to follow through with that if you're clear on those things. So what about your current use? Do you want to be different? And kind of exploring that. So it could be cutting back and being in that less risky use. So maybe I just do a trial of managing or moderating my use to having less than 4 drinks a week. Or maybe I want to do a trial period of abstinence and just see how that goes. Just see, how do I feel differently when I don't use alcohol at all? Do things get better or worse? And then I kind of have that proof for myself of, what looks different when I make this change.
It's interesting. I don't know this, so I don't know that how many people would, but if you were to be sitting across from someone and starting to get to know them and understand the grip that alcohol has, this is my language, but on their life, you'll ask them, what is your goal in all of this?
Yeah.
And then work with them towards that goal. And an assumption here, but if you're sitting there listening and you think, well, there's a healthier goal, you maybe will have restraint, but didn't help them move somewhere on that kind of like scale. Whereas back to the black and white model, there's either like all in or all out with alcohol. I think it could be comforting for some people to know that if they're courageous enough to say, yeah, I'm going to go talk to someone about this, that the response to them isn't going to be, well, you just got to stop right now.
Right.
Not that that's not right for some people. I'm sure that it is.
That's right.
But it sounds like it depends where you are on that scale.
That's right.
Yeah.
I think many people are surprised about that in counseling. They expect somebody to just tell them what to do, to be different. And I can't speak for every counselor. I can speak for myself, though, and for many other people I know take the same approach, that it's a totally self-directed process. You get to choose what you want to do differently. You get to choose what you want to talk about. And I can be there to let you know what the data says. I can let you know what the options are and maybe give you some ideas of things to try and kind of come alongside to help you problem solve. But you're totally the one driving the car.
Love that. When someone comes in for the first time to connect with you and have these discussions, and let's just say, hypothetically, I'm building towards a question here, but you have a great session, whatever that looks like. They were open, vulnerable, receptive, agreed, yes, I'll put these, this plan into place. I'll try to step back, whatever. What is the cadence that you would connect with them again, like a second time, third time, or what does it look like when they walk back out onto the streets, but when they go back out and come back, just kind of walk through, what does that overall treatment plan look like for your clients? Because it's maybe in what I'm about to say will help you kind of direct how you answer to it. But I know that in the Alcoholics Anonymous world, so much of what they do is they have meetings, but then they're connecting with things like sponsors and connecting with peers. You hear about these diner sessions, everyone's meeting. My gut is, because I haven't been through that process, but like the frequency helps, the accountability helps. So what does treatment look like, big picture, overarching, when someone comes in? I know they're connecting with a counselor like yourself. Where do you go from there? And does that cadence, is it more intense when someone's further along on the spectrum and then more loose? Like, just kind of give us a picture of what it feels like to be in, working with you, actually.
Totally. Yes, it depends on maybe how severe things are. So we might recommend or talk about more intense options for somebody who's going to need more support. There are options where somebody might come in and be seen every day, or maybe not every day, but like 5 days a week or 3 days a week if they're in an IOP, intensive outpatient program, or a partial hospitalization program. So there are some really intense levels of care. The other end of the spectrum might be somebody may even come in and just see me one time and feel like they have clarity on what they need to do different and feel pretty confident that they can do that. If somebody wants some more ongoing accountability, that might look like every week or every other week. It really just depends on each individual kind of person's situation, but it is going to have more clear boundaries than something like a social group where you might see people really regularly. If you have a sponsor that you can kind of call in the middle of the night.
And on that note, if you think it would be beneficial for someone that you're talking to get plugged into one of those types of AA groups, in addition to seeing you or a colleague, will you make that recommendation?
Absolutely. My approach is I try to give the clients that I'm working with all the information I have available to me so that they can make an informed decision. I might tailor some of my recommendations to things that I know are going to be particularly relevant to them. But if somebody's telling me that they're having a really hard time changing their patterns, their behaviors, their use because they're steeped in it, everyone around them is doing it, it's hard to kind of get out of that. Sure, I'm going to recommend hey, one way that you might be able to change your support system or connect with people who don't do that might be in a mutual aid support group. And here's what those options look like.
It seems to me that your perspective is however you can get help, and you're going to recommend how to do it.
Whatever somebody's willing to do is what's going to work for them.
Yeah. This is a little bit more of a personal question, but not so much. But you said something there that I'm just curious to get to know you and how you think. But you mentioned sometimes people will sit in front of you for one session. You call it a session, right? A client session. And then you'll presumably never see them again. What does it feel like, assuming this has happened in 10 years, but what does it feel like when you sit across from someone and they walk out your door and you think, man, I want to help that person, and then they're just gone? What does that feel like for you? Because I'm assuming there's no closure.
Sure.
I don't know, but you can't email and say, hey, how are you doing? Because there's probably some guidelines there.
That's right.
But what does that feel like as a professional to to have that?
Yeah, that's a great question. I think that's part of our training is that we learn to set up those professional boundaries and be paying attention to our own reactions to things. And we kind of have a system for monitoring that. So we can always get supervision to kind of process that for ourselves. We certainly can reach out to somebody if we feel like there was more work to be done, or maybe that's just the way that we left things off is, hey, call me if you need to, or I'm just checking in on you. Mm-hmm. And more often than not, we don't get closure. We don't necessarily get that last, like, hey, we're on the same page about this. This is the last time we're going to see each other.
Yeah.
Let's talk about how things have been. That's an ideal situation. And it actually, in my experience, doesn't happen that often. And I think it's beautiful that when somebody gets what they need, but they can take that and do with it what they need to.
For you, that's sad. I wish you had more closure. I feel like that's important,
Well,
you know?
I think that's just part of how we manage our kind of professional well-being and our boundaries and things like that.
Yeah. I told you before we started, I would go on a couple of rabbit holes, but you just made me think of something. You mentioned the word boundaries, and it's important in your role to have boundaries. And I can see why, right? But it's funny because so I've had counseling, and I've actually had counseling here in Colorado. And at one time I saw my counselor like out in the wild at a coffee shop. I felt like I was like walking in on something, like I shouldn't see him. Like I was like, and I'm a
real
pretty
person.
Yeah, like I'm a pretty natural guy. I don't get uncomfortable a lot, but like I saw him and I almost, to respect him, I was like, is it okay that I say hi to you? You know?
Yeah.
Like you want to have boundaries. I totally get it. But I'm assuming sometimes you do life, you know, where you work and you probably see people and you just know how to navigate, I'm assuming.
Yeah. I try to be proactive and kind of talking about that in the first time I see somebody, like, hey, if you were to see me at the grocery store, this is what you can expect from me. Just as a way to kind of set the stage for those boundaries. But yeah.
We're not going to be doing HIIT workouts together.
Yeah.
Basically. Right. Kori's a big HIIT workout person, but we won't go there yet. I have a very, very specific question, selfishly. And I hope the answer will help listeners as well. But I know someone who struggled mightily with alcohol. And he had this trigger time of day in or around 5 o'clock. Because transitioning out of a headspace of corporate pressure, stress, responsibilities, etc., working from home post-COVID, transitioning directly into taking off, flipping the switch, putting on another hat, whatever, dad, right? And it would even be where I get off a call, I'm wrapping up things, I have 11 things that I still have to do. So to feel as though I've controlled that day, and control is a whole other topic for me. We can go deep as heck on that. We're actually in a mini series right now about control. That said, when I would move from work without being able to resolve those tasks, whether it was I got to send this email, I got to check this box, whatever, if I would be disorganized and just out of haste, moving out of work because I knew that my wife needs my help, my kids are acting from the other room, and I would move right into that next role without being able to put a bow on that day and plan for the next day, so uncomfortable for me. And the next thing you know it, I'm responding to powerful emotions from toddlers and I move right in. Let's just say in a scenario, my wife goes right out the door because she has somewhere to be. And now I'm managing these 3 kids. That's one scenario, but that transition from one to the other over time, it turned into whether or not there was urgency or stress, I felt it, perceived or real. And what I developed was this bad habit of turning to alcohol, because it would very effectively, even if it was some weird combination of placebo and the actual alcohol, it comforted me knowing that like I had this little, I'm doing this, but like I had this little escape, whether the can was over there on the table, knowing that it was there for me, it made it easier. And because it made it easier, I turned to it, and then I had to turn to it more and more. And then it became a problem that you would ask me about, right? Yeah. The way you've been nodding along, I can tell you've heard this before and you get it. But a real practical kind of like question that I would ask you is, when I recognize that that's my habit and it's getting worse, what do I do about it? Because what's not going to change are the circumstances.
That's right.
Right?
That is kind of at the core of changing our behaviors, is kind of understanding what's driving this, which is that discomfort. I don't feel done with this and I'm walking into something hard, like I'm feeling stressed, right? And being able to have ways to manage those emotions that don't have the negative consequences that might come with alcohol or other things. So at the core of it is an ability to identify our emotional state and be able to manage that in a healthy way. And disappointingly, that's not something that we are explicitly taught how to do.
Unless I'm sitting with you.
Right.
I'm assuming.
So that it is difficult work to undo a pattern, a habit that we've operated from maybe our entire life, right? Being able to tune into our emotions, know what they are, being able to sit with hard emotions, figuring out that we can experience them and get through them and sit through them and survive. And being able to kind of change that when we need to, using things that are effective, like breathing, exercise. That list is pretty extensive, but that I think is the value of working with a professional who understands that and can guide you through that process.
Yeah. Yeah. And as I'm talking to you hearing you respond, what's really kind of coming full circle is even when I introduced you as a licensed professional counselor and also licensed addiction counselor, because you have training in both, if you're meeting with someone who does not identify with having an issue with substances, you can help them just with managing the stress of daily life. Let's just say they haven't turned yet to a substance. You can help them there, but you can also help someone who is turning to substance because of something else, like the root of the root of the problem, the deeper problem. Ultim, plug there. Ultim's Latin for deep. But and that's what it's about. It's like, and that's what I found where I think the labels of, say, in Alcoholics Anonymous, where it misses so importantly, is you're in that room, you're in that meeting for a reason, and that reason is deeper than the substance itself. I think, a little bit of a speech here, but you're giving too much power to the substance without addressing what caused you to turn to it. And yes, to your informed point, some of it could be genetics, and you could be predisposed. But what else? What's the pain and the discomfort that, in my case, is making me turn to that? So, and that's tough.
Yeah.
With alcohol, you used a term before when you talked about it. When I first asked you about it, you said it's the, quote, current way.
Yeah.
Acknowledging that it's changed. Where do you see the treatment of alcohol use disorder going in the future? You foreshadowed earlier that there's some tools or there's some things that we're using to kind of combat it. But like, where do you see it going? What's next? And talk us through that.
I think there's some really interesting things that I've heard in conferences and in research. So interestingly enough, I think there is some work being done using psychedelic assisted therapy. That's a whole rabbit hole too. It seems like there's more about that coming out. There's lots of trials that have been wrapping up over the past couple of years. So I expect that we're going to continue to see more about that. Without getting into all the reasons why, I think there is a lot of funding for research on medications. So I'm sure we'll continue to see different medications come out. And regardless of maybe your stance on medications, there's undeniable value if there's something that can keep somebody from dying. So sounds like there's some work being done on things that might work towards that. So medications are always something that, gets a lot of attention and funding. So I'm sure we'll see more there too. There's also just a lot that we still don't fully understand about the brain. And as we come to learn more, that helps us to inform our kind of treatment approaches and options. So I'm looking forward to what comes out of that as well.
Yeah, you mentioned earlier, you said the word trauma. And that just since starting this show, I think you're the fourth guest who has brought up that word specifically. I'm sensing that more and more people are starting to open up their understanding or I'd say accept that trauma is much more prevalent in most people's lives than they might expect. I've heard like capital T trauma and lowercase t trauma. I don't know if that's a clinical term.
Big T trauma,
Big T, yeah, thank you, big T. I think more people understand that you don't have to have big T trauma to have experienced trauma. And to the psychedelic portion of it, a psychotherapist that was on this show, Benoit Kim, shout out to Benoit, he defined trauma as a breaking of a pattern of which the pattern implied safety. And it was his own way of defining it.
Sure.
And what he explained to me that what medical professionals, researchers are starting to find is that there are things like psychedelics or maybe medicines that can expedite the healing of the trauma, or at least
Yeah.
the awareness of it, to aid alongside a comprehensive kind of treatment plan.
Yeah.
So you kind of get where you're going faster. Is that kind of?
Yes, there's really interesting things that we don't fully understand yet, but we do know that our brain can make lots of new and different connections with psychedelics. And that process does happen significantly
Quicker.
faster than it would without them. One of the things that I think we need to know more about is like, how is that happening? And how do we keep that, how do we keep somebody safe? And are there things that we can do to prevent negative experiences? I would say it's a little bit like the Wild West. It's exciting, and there's still a lot that we don't fully understand. And I think that will, over time, just give us some really cool options.
Public service announcement. Kori is not saying go to Burning Man and smoke ayahuasca. That is not what she's saying.
No.
These are controlled settings.
We know set and setting are important.
If I was listening, I would be asking myself that question of, I guess, how I would phrase it internally, what I would actually probably literally Google would be in the privacy of my home. Do I have a drinking problem? That's what I would probably Google. I don't know that I would know the terminology, but if someone is still kind of like listening and thinking through that, how would you advise them to answer that question? And then what would a next step be?
Yeah. I do have a biased opinion in that I think talking to a professional can be really helpful because we are kind of an unbiased, as in we don't have a personal investment in your life and your outcomes necessarily. And so we can give some of that feedback and even just maybe even reflect things back to you so that you can hear them in a different way. And that can help somebody get clarity or even just learn kind of what change options might look like. That being said, if that's not accessible to you or you're not interested in that option, I think you can always approach change with just a sense of curiosity and say, I'm going to try some things and see what seems like it helps the most. So as I mentioned, maybe I just cut back or set some limits for myself and see if that feels more manageable. Maybe I do that trial period of abstinence and just see how I feel differently and see what else changes in my life. You could work with a coach or even just invest your time and energy in some things that you know are good for you and see if kind of balancing the scales gives you the result that you're looking for.
Yeah. I'm going to see what your response is to this. Back on that hypothetical, if I were to be searching that, because something happened in my life where I'm like, okay, enough is enough. To me, getting in a chair like this in your office across from someone like you is getting it wrong, spending a lot of time trying to find, because the first question is, where do I go? Because in that Google search, I'm assuming there's going to be like treatment centers, facilities, counseling, health systems that are serving ads
definitely.
to me. Right? It's going to be like,
it's going to be all here. Residential treatment facilities.
Yeah, because they're for profit. Some of them, most of them, they make money, right? And that's great and that's fine. But it can be overwhelming.
That's true.
To scroll that, and then so what I would probably do, and this is a long hypothetical, but I might call someone I know that also had an issue.
True.
Try to find a way. So navigating that first step to getting in this chair across from someone like you can be overwhelming. Especially if when I needed the most help, my margins were so low between traveling for work, being a dad and husband. So I guess a question would be, it's like acknowledging that it can be tricky to try to find somebody that's going to help you. And then there's the risk of you get in front of that person. And I mean, you got to establish trust and rapport.
Absolutely.
To be able to make any progress. Yeah. There's the risk of like, I'm going to go through all this and I'm going to sit with someone and I'm going to walk out and be like, no. And maybe it's easier for me to just maverick it and just, to your point, just will it, grit of my teeth, cut back. And the question would be like, what is an easy way, or do you have any tips on how people can kind of navigate that and make sure that they find the right provider, I would say even right partner in this journey, and they'll have a success in that relationship? Like, what's some ways to do that?
Yeah, our healthcare system is complicated unnecessarily. So there isn't necessarily one place to go. I will say, like here locally, our health district has a program to help you get connected to a therapist. So it's like one phone number, one place that you can go. They can kind of facilitate
amazing.
that. Yeah. So it's somebody who is aware of all the options and kind of understands how to access those options. And they're a middle person that can help get you connected. So some people want that kind of support. There's also things like psychologytoday.com, which is like a therapist directory. I know I'm not necessarily endorsing any one thing, but just to say that there are directories like that where you can type in your zip code, it's going to pull up, and you can put in your insurance, or if you want to pay out of pocket, it's going to pull up all the therapists that are around you and tell you whether they're taking new clients or not. They have a bio on there, so you can kind of get an idea of what they specialize in or what approach that they use. So you can get a sense of like if that person might be a good fit. And then I would always tell people you can call a counselor and they should be willing to offer you like a consultation so that you can get a sense of if it's somebody that you feel comfortable talking to.
Yeah, it's funny you say that because when I did find the counselor here in Colorado, I did a search, just like I said, and I didn't search for psychology today. Is that what you said it's called? Yeah, but that's where I landed. And then I went to a website, and what was all this to say, what was helpful for me, what I appreciated was every counselor at this practice had a bio.
Yes.
And it shared personal information and a photo. And I literally feel like I was on a dating site. Like, not that I've been on a dating site, but I scrolled and I was like, and I was like swiping down. And I'll tell you what, the gentleman that I found was amazing.
Yeah. That exists for the reason that you said, you know, we want to go into it with some level of confidence that I'm going to be able to connect and trust this person. And of course, we can't know that for sure off of a one-page bio, but it at least gives us the opportunity to say, actually, I don't think that's going to work for me.
Yeah.
I would also say, you know, we can all relate to maybe seeking other professional services, and we do the same thing, right? If I'm going to go get my hair done, I'm going to make sure that this person can do the thing that I want done, right? If I'm going to go see a personal trainer, I'm going to make sure that they're going to offer something that I'm interested in. So we can do that same kind of screening process when we're seeking professional medical services too.
Yeah, can and should. Yeah.
I would encourage it.
Yeah, it's so relational, I feel like, a situation like this. I only have two more questions for you. And one of them is all about you, in that I want to make sure that things that you're passionate about, things that are important to you, if you could say one or two or three things to anyone listening that, again, is exploring this whole topic of addiction, maybe alcohol abuse. But if you could say one thing or get through one point, what would it be?
I think the biggest takeaway for me would be you don't have to identify as an alcoholic to decide to change something about your relationship with alcohol. And you don't even have to commit to any one change in order to maybe find ways to better manage your well-being, your emotions, your relationships. So I think doing our best to keep an open mind and knowing that there's all kinds of pathways and options to healing and recovery, and that might include professional things, it might include social things. You might not ever talk to another person about it. There's lots of different options.
It's comforting to hear that. My words, not yours, but essentially by raising your hand and saying you want to explore getting help, you're not buying into and signing up for some permanent label. And then there are different ways to, quote, solve that problem. There's not only one way to do it. Is that a fair summary? I love that. I think a last question that's important is, what are some resources if someone's not ready to sit in a chair and not ready to physically place themselves? But where would you point them? You mentioned Psychology Today. I just got a resource for therapists, but any other resources that you would point people towards?
Yeah, I do believe that knowledge is power. So if somebody even just wants to look at some of the research around alcohol or other substances and decide for themselves if it's something that's posing a risk to them, I would say the best place for a lot of that information are some of our kind of big government sites. So I'm going to preface this by saying that they have outdated language in their name, because these really big groups, it's very hard to change your name. So one is the NIAAA, the National Institute on Alcohol Abuse and Alcoholism.
Which we've learned those.
Yes, I know.
Okay.
So this is through the NIH, but they have a lot of information about different treatments, about kind of the effects of alcohol, prevalence rates. It's just a good place for data. And the other option would be, for alcohol specifically, there's something called SBIRT, Screening and Brief Intervention.
And we'll link to everything in the episode notes. But say that again, SBIRT?
SBIRT.
What is that?
So this is like a screening and initial kind of brief intervention tool for alcohol use. And this is sponsored through SAMHSA, Substance Abuse and Mental Health Service Administration. So they have some guidelines on there about risky drinking and what is a drink. So they define what a drink is and what the levels are for low risk and high risk drinking. And so that would just be a good place to start to get informed yourself about kind of what's going on. And maybe that will help you decide what option to explore first.
Awesome. Okay. And we'll get all those details from you and we will link to them. Kori, anything else you want to share with listeners?
No, I don't think so. I'm super excited to talk about this and I appreciate you creating the space for it.
Thank you for taking the time to be here. Thank you. Kori Turner, everybody, thanks for joining the Live Deep podcast.